So this came together because I feel as physical therapists, we're the conservative approach to pain versus surgery. And I thought, what are other conservative approaches that people want to know about? And we as physical therapists get asked all the time, you know, what's PRP, what's shockwave, what are peptides? I haven't heard many about peptides. And I thought, what better opportunity to bring everybody here, have 3 physicians talk about the different aspects of one of their specialties. Now, by the way, probably all these doctors know about all 3 of these areas and probably could answer questions on it too. But I thought this would be a great opportunity. My vision was to have a bit of a TED Talk where they speak about something for 15 minutes. Then we'll have 5 minutes of questions, and then we'll go on to the next topic. If your question didn't get answered, we'll have time at the end also to answer some of your questions. So think about your injuries or pain if you have them. If you're over 40, you probably got something that hurts, right? Everything from shoulder tendon issues, knee swelling issues, hip issues. These were some of the things that I wanted the team here to address. I do have to say, I asked AI today, how do you conservatively treat an injury? AI said, rest, activity modification, heat and ice, non-steroidal anti-inflammatories, physical therapy and strengthening exercise, corticosteroids. I said, AI, she's a girl in my house. Why did you not even talk about any modern advances that we're utilizing besides surgery? And she said, oh, thank you, you're right. Emerging and modern treatments such as shockwave, peptides, and platelets, or PRP injections, are increasingly being used as advanced non-surgical options. So tonight, and she thanked me for asking that question. So with that being said, I'd like to introduce our physicians. So first off, I'll have you guys take a seat. So Josh Sampson's going last, so we'll put you in the first seat down there.
All right.
And I'll give you bios on each of them. Kristen Wingfield. And last but not least, Dr. Massey. Harris Massey. So I have lots of teenage boys around me. And if you have teenage boys around you, and especially when you go to college campuses, they're all about peptides. And so therefore, I have asked my sons about peptides. And they're all over it. There's like, Mom, there's this, there's this, there's this. And when you go to the college campuses, they all want to talk about peptides. So I'm the cool mom because I actually know what the peptides are all about. When I ask my peer group, such as my swimmer friends, I go, well, have you heard of peptides? They're like, well, it's in my face lotion at night. And I go, well, I'm not talking about those peptides. So they didn't really know about peptides. So have you heard of Ozempic? That's a peptide. So tonight, I would like Harris Maskett to tell us about peptides. And let me tell you a little bit about him. He's a board certified, by the way, your bios are all brilliant. I shrunk them a little, if that's okay. Dr. Harris is a board-certified internal medicine with specialized training in sports medicine. He has a passion for optimizing health and athletic performance. He is dedicated to helping you feel good as you possibly can for as long as you can. His background includes working as a team physician and urgent care physician at UC Berkeley, leading the performance lab at Blue Wave Medicine. He serves on the medical advisory board for USA Ultimate and is the team physician for the Oakland Spiders, which is what sport?
Ultimate.
Ultimate! He's currently practicing out of Jason Integrated Medical Clinic located in Mill Valley. And also something fun on his bio is that he does stand-up comedy, and so he might be funny too.
No pressure.
I did stand-up comedy, so I'm not funny anymore.
Okay. So please come up.
Okay. It's a little fuzzy. Are we gonna unfuzzy or no? If not, I'll just, I have little notes so that can work. Oh, perfect. Oh, hey. All right. All right, let's get a show of hands. How many people coming into this have heard of peptides? Not collagen peptides, the other peptides. Fewer people? Okay, cool. How many people knew a GLP was a peptide? GLPs are like Ozempic. Okay, great. It gives me an idea of what we're talking about. So I'm going to explain why they're popular. Why are they hot right now? What are the common ones? What are the ones that we're hearing about most in my clinic and on the internet and such? And then what do you need to be thinking about in terms of regulation, risk, potential benefits? So a peptide, just so we have terminology, is a chain of amino acids less than 50 in length. More than 50 is called a protein. It's kind of arbitrary. It's essentially shorter than a protein. But your cells, in the basic physiology, spit out these little messages. These messages are often called peptides. Some are proteins, some are larger than that. But these little peptides that we're talking about are made by your cells. And you can imagine if you just went inside the body and looked to see what the cells are making, they're literally making thousands of peptides all the time. So somewhere along the pathway of basic research and science, or you're looking for a drug and you're following a pathway, you're trying to understand what's happening, you discover, hey, there's this little peptide, I wonder what it does, and you discover it does this, it does that. That's how peptides are discovered. So when you get that moment, this aha moment where you discover a peptide and you say, it does this, you say, well, can we make this into a drug? Can this help? Can this be helpful to people? Can we make this into a supplement? So if you go the path of making it into a drug in this country, you're talking about 10 to 15 years and $1 to $2 billion for a successful drug. That's quite a barrier, right? And that means that most of us won't ever see whatever that person had that aha moment with, that peptide. So there's another way where this person can say, I could make that, and suddenly they're making it. That's no regulation. So somewhere in between is where peptides are. Every possible process you can imagine is how the peptides have gotten here. And I'll tell you about a bunch of them. But some were drugs that were on the way to becoming a drug that you would prescribe and send somebody to CVS to pick up. And then halfway through the process, they pulled funding, they said, forget it. We don't like this one, it seems risky, we won't make money. Some were developed in other countries, and they said, by the time it hit the market, there was no point. It's already in the market. People are buying it. So peptides have come a number of different ways. But what are they? They're little messengers from one cell in your body to another. And what I feel like my job is to do is try to understand the basic science so I can have an idea of what we're even talking about. Okay. Sound good? Okay. Let's talk about common peptides. The most common one you'll ever hear about is BPC 157. Raise your hand if you've heard of BPC 157. Wow! I was expecting everyone's hand. Okay.
I told you.
BPC 157 is a peptide that started being used by athletes and people in performance and the performance landscape. And the reason is BPC, the peptide itself, is made in your stomach. Your stomach makes it and sends it to the other cells in your stomach to recover from injury, to heal from maybe exposure to acid and difficulty with managing that. So BPC is actually a compound that is made inside of you. What somebody realized was this BPC, if you send it to the rest of your body, also helps other tissues heal. And what they started noticing was it creates a thing called angiogenesis, more blood vessels going to areas where where we need more healing. It makes collagen form more easily. It makes growth hormone go up just a little bit. So people who use BPC 157 notice they don't have as much pain. If they have Achilles tendonitis, it heals faster. If they have an elbow that's sore from tennis elbow, it heals faster. If every time they work out, their back hurts, it hurts less. So that sounds wonderful. You're like, now where do I sign up for BPC 157? The issue, though, is that it was brought to market after it was studied in Europe, and they discovered, okay, this is the basic science. It works. They used it on a lot of animals. They used it on a lot of people, and they said it worked, but it was never brought through an FDA regulatory process. So there are some things missing then. What's the best way to store it? What's the optimal dosage? What are the downsides? What are the risks? All of that wasn't as well studied as you might imagine Tylenol or atorvastatin. Maybe Tylenol is a bad example.
Yeah.
So because it's not as well studied, it's a risk, and we'll talk about that here, but that's just what BPC 157 does. I have athletes who come to me on the sly and say, listen, I need to get back into the NFL. I've had surgery. I hear this works. What do you think? Suddenly, that's a big moment. We have to have a really serious conversation. And if I don't give it to them, others are. So we also have people who are 16 saying, I need to ski with my son this winter in 2 months, and I need to get in shape, and I need to push myself really hard, but my back hurts every time I lift weights, and all of those things. So people are using it for the whole range of reasons, musculoskeletal. All right, another common one, thymosin beta 500, TB 500. Raise your hand if you've heard of that one. No shame in not having heard of that one. Okay, now TB 500 is actually a fragment of TB4. TB4 is being investigated as a drug, FDA approved drug, 10-year to 15-year, $1 to $2 billion. TB4 has been shown to increase healing times or slow the inflammation, the inflammatory response to cardiac injury, to NAFLD, which is inflammation of your liver, to ocular injury, or in sepsis. So TB4 is being studied, it's going through all the trials, and it will probably hit the market if it's successful in 5 years or so. The fragment of TB4, that's TB500, just works on musculoskeletal tissues. So if you have a muscle strain, if you have tennis elbow, if you have Achilles tendonitis, it's helping those things heal more quickly. Who's heard of growth hormone? All right, that's a popular one. So remember the 1980s and 90s? A lot of athletes use growth hormone, and they had real serious trouble with that. And that's when we started learning that growth hormone was secreted by our bodies in this pulsatile way. And when you give it to them nonstop, everything grows nonstop, like tumors and heart disease, and so it's a real problem. There are two very popular peptides. One's called, another weird name, CJC1295 ipamorelin and tesamorelin. And there's another one called sermorelin. Anyone heard of those? They're very popular. Okay, what those do is they go to the part of your brain that says pulsatile release of growth hormone, and they just make that go a little higher. And then it's out of your system in less than an hour. So your growth hormone, when you go to sleep at night, when you use that medicine, your growth hormone goes higher than it was going to. Your IGF-1 goes a little higher. You heal more quickly. You grow muscle more easily. You burn fat more easily. You sleep better. You're more cognitively sharp. Everyone's like, wait, what? So now CJC was studied, and it was on its way to becoming an FDA-approved drug, but somebody died in the study. Now they didn't directly link that person's death to this, but they died. And the company said, we're out. You have to understand these companies have a lot of drugs in the pipe, and they are making investment decisions all the time. So it was enough for them to say, forget it, but enough for other people to say, that was working, we're going to develop it. But they're developing it as a gray market peptide. Tesamorelin and sermorelin, those actually are FDA-approved drugs. Tesamorelin is used for HIV wasting syndrome. It helps people increase muscle mass and increase their appetite. Sermorelin was used that way, but stopped in the 90s, and now people are making it in compounding pharmacies as a growth hormone secreting medication. So, and the last one I'm going to tell you about, you've probably heard of this one. Have you heard of Ozempic? Have you heard of Mounjaro? The third one, or the next generation, I should say, that's coming out is called Retatrutide. Have you heard of that one? Retatrutide is trying to answer the problem of everyone's losing muscle mass with Ozempic and tirzepatide. What if we stimulate muscle growth while we give people, decrease their appetite? That's the whole next realm in this world, is Decreased appetite, increased growth hormone. I don't know where all that's going, but retatrutide has glucagon stimulation, which increases metabolism a little, and in the early studies, people are having less muscle wasting. So we're getting a lot of athletic folks in Marin who are not having a lot of weight to lose, but want to lose a little and not lose muscle mass, and so they're liking retatrutide. All right, let's talk about this one. Potential benefits, risk, and regulatory considerations. How am I doing on time, by the way?
You're good.
Oh, good. I'll just stretch it out.
5 minutes.
All right. Well, that's perfect. 5, 5, and 5. All right. Potential benefits. They hit the market fast. You know, I think it's really frustrating as a patient as well when you have all of this amazing science happening and yet it's not going to be available for 15 years, even if it's available. That's frustrating. So that's a benefit. And that's why people are using it, because they're saying, I want to try it now. I'm willing to take the risk. Okay. So that's a benefit of bypassing the longer, more expensive process. What are the risks? So when something is not made in a pharmaceutical, the FDA approved pharmaceutical pathway, then you have to get your head in a different frame. It looks like it's an injection. It looks like it's insulin. It looks like it's not Tylenol, but something else that you're used to. But it's not. It didn't come that way. And so you might think, well, it's probably safe. We don't know. It hasn't been tested in randomized controlled trials for years and years, so that 10,000 people we can say, okay, these are the series of side effects, and this is the dosing, and this is a bad way to dose. We just don't know. And so what I have as a discussion with all of my patients, because my approach, I'll tell you my approach to this, is the harm reduction approach, which to me that means I want to stay in the room with the patient. I don't want to say, well, I don't recommend peptides and I'd rather you leave and I don't want to talk about it with you. I had that with a lot of athletes 20 years ago where I knew they were using performance enhancing drugs. I couldn't talk about it with them, so I never saw them again, and I didn't feel like that was a good approach. I'd rather be in the room, know as much as I can about this, and say, here's where it's not safe. Here's what we should be checking. Here's a lab I would check. Here's how I would be cautious, or even more cautious than you could be. Here's the conversation I have. There's 3 things to consider. 1, how was this drug made? And there are labs all over the country. Some are cleaner than others. Some have an FDA approval stamp on them. Some have a third party that comes in and says, that's a clean lab, I trust it. Some don't. So I would check and see, is the lab where your BPC is being made, is it a good lab? Can they show you, yep, we're checked by a third party company, we're clean, they pull stuff off the shelves, they test it, and they say, oh yeah, that's BPC, okay, you're a good lab. So 1, is it safe, and do you even know? 2, are you comfortable with the idea that you are experimenting on yourself, that this is a risk, that this has not been done in tons and tons of people? Now, I had a 15-year-old in my office the other day saying, I want to do this. And I said, and are you comfortable with that risk? And the 15-year-old said, yes. And I said, Mom, are you comfortable with that risk? Because I know the right answer is that you have to make that answer. You have to answer that for your 15-year-old. They're not able to make that determination. But the rest of us supposedly are able to make that determination. Are we comfortable with that risk? And I ask my patients, are you somebody who wants to be the first person to try something? And we all have different risk tolerance. We're all dealing with a different situation. So it's really a very personal decision. The third thing, and this is the most important, let's say it works. Let's say it's safe. Let's say the lab is good. Let's say the dosing is right. Okay, well now you're taking something that is turning up a process that's normally cyclic, like things go up, things go down. There's a feedback process. You're turning off feedback and you're saying more BPC, more BPC, more. What happens when you keep a process of healing going and going and going and going? Might a tumor that you were about to kick out of your system heal? Might a plaque in your cardiovascular system keep growing? Those are real risks, and we just don't know. So I'd say to all my patients, dip your toe in the water. If you really want to try it, dip your toe in the water for a period of time and then pull back. And let's assess. Let's get labs. Let's see how you're feeling. Let's see what you're learning. That's the best way I can think about modifying your risk if you really want to do it. But there are professional athletes who need to do it. There are people who are in a lot of pain who really are willing to try a lot of things. So I like that peptides are here. I think it's an exciting time, but it's not without risks. And also to all of us who are prescribers, we have to have really careful documentation about what we're, what our role is here.
Awesome.
All right,
Thank
that's
you.
my spiel.
Yeah. Perfect.
Are there questions?
I have a question.
I
Mind
think
blowing,
I
huh?
saw that hand pop out first. So I'll
Yeah,
get
go
you.
ahead.
Sorry.
Yeah.
Where are people, like, are you prescribing it, or where are people getting it?
I can't prescribe a medication that is not a medication.
Right, that's what, like,
So if you go online, you will find one really quickly. You'll find probably a whole page of this company, this company, this company. What they are research labs that make compounds for research. Now some will say they make these for research studies, and some do. Some just say they make these for testing. Some will say not for human use. And some don't have a website you can find. It's sort of a hidden URL. And then some spas and medical clinics will actually just bring them into their practice and just have them there for people to get, saying, we bought them from somebody we trusted. The clinic I work at, Jizen, does get them that way. They have them brought in from a company that they trust and worked with for years.
so a lot of the time, like, obviously, a trusted source like you guys and spas, hopefully, like, are referring the right things, but if somebody's getting them on their own, they obviously have to do their own research into that.
Yeah.
But it's pretty easy to also just get one that's not researched well.
Very easy. I had a patient recently who said he was using BPC. I said, where'd you get it? He said, peptide something or other online. And I'm like, how long have you been using it? He said, 4 months. I'm like, oh, you're just doing this.
Yeah.
So that's why I'd rather be in the room with the guy and help him think about it.
No, fair.
Yeah.
Fair.
Did you have a question? Yeah.
Yeah, what kind of a situation if a patient came to you, what kind of an injury or illness or pain relief might you consider recommending a peptide?
I tend to think of it more for soft tissue pain, like a shoulder that keeps being sore, an elbow that keeps being sore, like a tendinitis, a rotator cuff tendinitis, back pain that is not necessarily a disc or bone, labral tear, patellar tendinitis, jumper's knee, Achilles tendinitis, plantar fasciitis, the greater trochanteric pain, some lateral hip pain, a lot of things. And I would think of that for all of the ones I mentioned, except for the hereditary type. Yeah.
Has this been studied, whether officially or unofficially, for interaction with other drugs that are common for people to be taking, especially as we get older, for things like blood thinners and blood pressure medication, statins, you know the list.
Yeah, you know the list. Yeah, I'm with you. Not that I'm aware of. And the question for those that didn't hear it, has this been studied in combination with other medications? One of the things that doctors always have to do is put the drugs on that little website that says, all right, here's how they interact and here's how you change the doses. These have not been tested that way. Now, those that were going through the FDA process of approval, they have. There's a lot more data there, but some just haven't gone that far. Yeah.
In your practice, I'm sure you use these other methods that people are going to be talking about. When do you go with peptides? Is it after you've exhausted everything else, or?
So peptides are helpful for, the things that we've talked about, and so are Shockwave and so are PRP. If somebody is having an Achilles tendinitis that's just really sore, and they're going to do something like Shockwave therapy to help that healing improve, at the same time, it would also help that healing improve if they were using peptides.
So you do.
So you can combine them. Some people say, I'll just start the peptides and I'll get back to you if I'm not better. Some people say, I'll do the Shockwave and then I'll let you know. But combining those different modalities hasn't been seen to be a risk as far as I've researched. Yeah, back there?
Do you have a favorite peptide? They all seem like they did kind of, since there was a little bit of overlap. Do you find that your experience so far is that you find
I mean, it's a good question. Favorite peptide? I mean, for the world right now, I'm really excited with the GLPs. There's lots of downsides and upsides and all of that, but it does seem to be having a huge impact. And I'm really curious about the next round where that might have an impact on the muscle loss, but also curious to see the downsides there. I've done a lot of research on BPC 57. I feel like I've read every paper, and I tried it myself, full disclosure, because I was training for something, and I thought, let's just see what that's like. So at least I can be, connecting again with a patient that way. I was willing to take on that risk. It was interesting, and so I found like, okay, that was good to know. So I guess that's my favorite one because I've used it.
Are these all used orally?
So the question was about the route. Most of them are injected, subcutaneous injection. Some people say you should inject the BPC near the knee that hurts or near. I don't think there's good evidence for that, and I think you get into really messy situations trying to put it into something. People mostly just put it into their soft tissue, right into the skin. It's pretty easy to ingest. There is an oral version, but they don't tend to work very well.
So stomach, pinch a little, put it in.
Pinch your skin, poke it in.
Yeah.
Yeah.
That's a good question though.
Is there any evidence for stacking the peptides?
So stacking was the next question. Probably heard the term Wolverine stack, which is a few different peptides all together. I love that name. I mean, it's so much fun to say. But there are people who stack peptides together, thinking that they'll have an effect that's greater because they are together. I'm not a big fan, to be honest. I feel like I haven't seen anything that shows me they work better, they're safer, it's a better idea. And I'm always concerned about side effects. And so I'm telling everyone, listen, if you're gonna dip a toe in the water, check one drug and see what happens to you and make sure everything's okay before you add the next one. But some people aren't happy with that and they're like, I'm gonna stack. I'm like, okay.
All right. We are going to move on. If you have more questions afterwards, thank you very much. That was awesome.
So, Shockwave. I've been a therapist for a while, and I think it's interesting to be a physical therapist because people do come to us and ask us about things. And as soon as, Shockwave's been around for 30 years. How long's the internet been around? Probably not that long. So we couldn't, I have even swimmer friends come in and they're like, what do you think of Shockwave? I'm like, I don't know what it is. And so over the years, then we have the internet, then you have my female AI, and then we can start asking questions when patients come in about it. So that's what's been interesting is the acceleration of Shockwave. Probably 20 years ago, I had doctors asking if we had it here. I'm like, no, we don't have it here. It's very expensive. I don't understand it either. And then over as I go to the private practice conventions, more and more physical therapists and physicians are talking about Shockwave and the great benefits of it. So I am so excited to have Kristen come and let me tell you guys a little bit about her. Dr. Wingfield sees patients in both Marin County and San Francisco. She's board certified through the Canadian Academy of Sports and Exercise Medicine and fellowship trained at Stanford University. She grew up as a gymnast on the Canadian team, became an elite springboard diver, and went on to a career in performing with Cirque du Soleil. She's currently the medical director of the Wellness Center of San Francisco Ballet, an elected member of the World Aquatic Sport Medicine Committee, where she worked at the Paris Olympics this summer, overseeing the medical care for athletic athletes. So that's yay, our swimmers. Well, I got a bunch of my swimmer friends here. So Kristen, thank you.
So, hi, thanks for having me. It's nice to be here. Yes, so there's lots we could talk about. So Shockwave has been around for a while. I remember when I trained at UBC and I was doing a lot of sports medicine, there were a lot of sports medicine physicians were investing in these new machines that were sort of a takeoff off of lithotripsy, which is a machine used to break up kidney stones. And I think it started in England, and so doctors would invest, and it was fairly invasive and painful, and you'd have to have anesthesia, and this was a system that was being investigated to break up calcium and tendinitis and calcific things, and so it was one of the experimental treatments for tendon problems that we've been trying to treat for so long. And then it sort of fell away, and then it became a little more advanced and modified into these smaller machines that weren't as high frequency and high energy and painful, and now we have these sort of units that are, so big that deliver what's called a shock wave. And so what is shockwave? It's a focused acoustic sound wave. Now there's also radial acoustic sound wave, which isn't as deep and focused, and it's a little more superficial, and some physical therapists use this. I don't think it's the same category of machine, so there's different categories of risk, and so some machines are class 1, 2, 3, 4, shockwave, focused shockwave, class 3 and 4. 4 needs to be operated by a physician only, and so there's different criteria for who can buy and use these machines. And so focused shockwave is a focused acoustic sound wave. So it's called shock because it's pushed by electricity. So it comes through a machine, and the sound wave is focused and directed into tissue. And so we focus it into a point or a linear point versus radial, which sort of goes around and is more like, laser ultrasound, a little more superficial. And so these focused acoustic sound wave machines operate through mechanotransduction. So it's a mechanical stimulus that goes into the tissue and creates a biological reaction. And so I sort of give the analogy of a trigger point massage or a needle in acupuncture, where it creates a local release or change in the tissue, except the sound wave goes into the cells themselves, the tenocytes, the debris helps all the cells that clean up injury and helps increase blood flow. So it's a little deeper. So we're talking about, and then the next deepest step would be needling and putting in platelets or other types of injections. So it actually goes into the tissue and stimulates a change, and it stimulates a cascade of events, all these different, works in different ways. It's not just one thing that increases blood flow, but it does all these different things. So one of the things it does is it floods the pain receptors with substance P, which is a pain transmitter, a neurochemical. And so it is a painful modality, and it floods the pain receptors and then turns them down a little bit. So during the process, it's painful, and the pain is turned down. It increases nitric oxide production, stimulates nitric oxide production, and we know that nitric oxide is a vasodilator. And so it stimulates increased blood flow. And when you're actually putting it on tissue, it's funny, you could watch and the veins dilate a little bit, and it helps dissipate swelling. It's very interesting. It increases cytokine release and all these sort of tissue reactions in the cells. It can help with collagen formation. All these sort of regenerative techniques that we talk about are really aimed at helping pain, reducing inflammation, and increasing healing. And in many of these injuries, the body gets stuck. And so particularly in high-level athletes and performers and lifelong runners and people who do a lot of activity, their tendons degenerate. And so we know that these tendon injuries are not necessarily inflammatory, like you tear it and it rips and it's swollen with fluid. It's more of over time it wears out. And so you get micro tears in the tendon. Tendons heal with scar tissue. They don't always have the best blood supply, which we try to increase with all these different techniques. And so they tear and heal and tear and heal, and it becomes a degenerative process, and the tendons thicken over time. Along with that, we know that there's new nerves that form, and the scarring attracts the new nerves, and it blocks the blood flow in. And so some of the newer techniques we use for tendon injuries are we dissect the tendon away from the tissue below. You can actually see calcifications in the tissue below the tendons, and you can put PRP or not put PRP, and you can try to break up these scarred areas. And so shockwave helps a little bit with that and can help reduce some of these adhesions and calcifications on a lighter level than, say, a needle and injecting or dissecting or stimulating change with the needle. And so these tendons get stuck, and so we're looking for all these techniques to help move them along. And number one is exercise. And so physical therapy, special exercise, eccentric training, not overloading the tendon, backing off, and trying to strengthen in a pain-free manner. And sometimes the pain is inhibiting, so some of these techniques help fix pain, shockwave being one of them. And so, shockwave is now being applied for delivering drugs and treating things in the brain and the heart. It's being used for all these different problems, but in musculoskeletal medicine, I mainly use it for soft tissue injuries. I think you can use it for arthritis. I haven't seen it work as well, and probably have to do a lot of treatments. And does it really change anything? Not sure, because that's another degenerative condition in the cartilage and the bone. But for soft tissue injuries, it's really helpful. Now, I'm pretty selective. I don't think it works for everything. Blanket, you know, if you have a big tear, Shockwave isn't going to heal that. And so that's when we then will go to needling, PRP, other techniques combined. But it is very helpful for painful conditions, which could be acute, like an ankle sprain. We have a lot of swelling and some damage that can help calm that down, and chronic, like patellar tendinopathy, Achilles tendinopathy, hip pain, greater trochanter pain syndrome, tendinopathy. Once there's a tear in the tendon, it's not as earth-shattering. It can help, but then you sort of need to go to the next level, which is some nuanced needling, PRP, time down, slowly strengthening. Shockwave works great for basic plantar fasciitis, hip tendonitis, bursitis, you know, some tennis elbow. It helps the tendon. It depends on the pathology though, and the degree of trouble in that area. So usually we recommend 3 to 5 sessions, and usually people see a change after 3 or 4 or 5, and they feel a little better. They might not be perfect, and I'll say go away. I personally say go away because it works over time, even after you apply the treatment, and do your thing, rest, do your PT, do non-aggressive, non-provoking exercise, and see where you're at. And then if you feel like it's better but you want a little more, you could do another series. So I'm not recommending, 20 sessions, and some people do that. Well, providers will just give 20 sessions. If it's not working, there's something else going on. There's maybe a tear, and you need to get more aggressive. You need to make sure you have imaging. I use an ultrasound machine, which is wonderful because I can see the tissue. I can measure the pathology of the tissue. Okay, the Achilles is swollen to 1 centimeter or 1.5 centimeters, and where do I want to target my Shockwave? Because we can tailor the depth of the beam with these little gel pads, and you can tailor how deep they go or how superficial they go. So today I was doing a wrist, and I was going into the joint and the TFCC, this little cartilage, and that was deeper than when I went. And then she also had a tendon issue, so we changed the heads, and you can measure it on the ultrasound and then target the Shockwave on another tissue that's at a different depth. So that's really cool. The other thing is that we use it a little bit diagnostically. So it tends to be painful and pick up stimulus in the pathologic tissue, which is really interesting because it doesn't hurt on the side that's not injured. And so it helps us find some injured pathology. We use this a lot. I work at the San Francisco Ballet, and we've had a Shockwave there for quite a long time, and sometimes we get these strange injuries that we can't quite figure out, and we'll put the Shockwave on, and then we'll look with the ultrasound, and sometimes we see little calcifications, things that aren't on the MRI, but the Shockwave always picks up the pain signal at the area that's most injured. And then it also helps improve that pain over time, and when patients come back and they feel a little better, their tolerance to the Shockwave goes up. And it's like that. I put it on my own issues. At the beginning, it's super painful. Plantar fasciitis is a classic one. The first time it kills, they're at the bottom level. And then as they get better, they tolerate more and more and more, and they start to feel better. So it's really interesting how it works. And maybe it's just modulating pain. Maybe it's not changing anything in the short term, but the pain modulation allows people to do more, which strengthens the tissue, so it breaks that cycle. Maybe it does stimulate tissue change. We don't know. But, with plantar fasciitis, if you can get it to a mild level that you can tolerate, who cares? It'll go away in a year. You just don't want to be limping around every day. So if you can get it to that level, and you're not doing damage and there's no tear, and you have to know those things, then it's okay to do that. And so everybody's a little different. And so, and sometimes you have an athlete with a little tear, and they want to try some Shockwave first, and you can just tell them, like, okay, it'll probably help a little, but you're probably going to need to do something more aggressive with that tear, which would be maybe some needling, some PRP, some immobilization for a short time, activity modification. And the ones that have more tearing or more pathology really don't respond as well to the Shockwave immediately. So it's kind of interesting. What else? Yeah, so I really use it in combination, and it's interesting to see how you space it. We space it out every 5 to 7 days for a series of 3 or 4, and you can then go longer if you need to. You can sort of stretch them out as the tissue's improving, and it's in combination with strengthening and some activity modification. With Shockwave, you don't necessarily need to stop things, like when you do PRP or you needle someone, they have to rest after generally for a phase, especially if you needle the tendon. But with Shockwave, you don't necessarily need to back off unless they come in and they're really sore. And the kids do great with this. The high school runners with plantar fasciitis or shin splints, they do wonderful with Shockwave. And so usually I'll have them back off while we're doing it for a few weeks, and then they feel better, and then off they go. We're using it for growth plates now for apophysitis, which is where the tendon attaches to a growth plate. And all these are issues. These are areas that we didn't ever want to touch with anything over the years because we've been scared about affecting the growth and the closure of the growth plates. And so all these gymnasts with hamstring apophysitis and Seavers and the soccer players, and do 1 or 2 Shockwave treatments on them, they're better. It's amazing. They do really well. So it's nice to have a little tool that we can apply to these inflamed growth plates and not cause damage and really affect their pain. It works really well for shin splints too. Sometimes it takes a little more, but it calms it right down. So that's kind of
Osgood
cool.
Schlatter.
Frozen shoulder, yeah, Osgood Schlatters as
Because
well.
those boys and girls, a
Yeah.
year of pain, that's great.
Yeah, it's very helpful. Frozen shoulder, it actually helps somehow break up the scarring and helps increase movement. It's the first time I've ever had a treatment that actually improves it. You know, we've always just kind of got people through until it gets better, maybe cortisone, maybe, you know, nothing, PT, but this actually helps them move a little bit better. It's amazing.
That's good.
Yeah, it's very cool.
Awesome. Awesome.
Yes.
So with like Seavers and frozen shoulder, like we see those all the time as PT, are you saying go immediately? Like if they come into us and they have this issue, should I say, okay, go get Shockwave right now and come back and we can give PT?
So it's not that easy, right? Because there are not that many around, not that many experienced providers, and it's hard to get in, and then you need to do series. And so usually it depends on their pain level, right? So some Seavers aren't that bad, and the kids modify for a bit, and then they're fine, and then they're on and off, and others are terrible. And so I think the bad ones, it can be helpful. And so it really is based on their symptoms, I think. Frozen shoulder, I mean, there's so many degrees of frozen shoulder. Some can't move, they have terrible pain. Some are fine and they're just a little stuck. And depending where on the curve they are, of the freezing, frozen, thawing phase, you can certainly recommend it in combination if they're really stuck. I think it is helpful. Yes? Anybody? Yes?
I recently had chocolate therapy in Berlin on my hip, and they also used laser therapy and cold therapy. Is that common here?
So class 4 lasers are starting, again, physician operated, and because they can cause tissue damage, the same with Shockwave, if it's put on a nerve for too long, or if you do too much on a tendon, a weight-bearing tendon, the theory is you could cause some tearing. So there's different types of lasers, and there's over-the-counter lasers you can buy on the internet, and then there's the higher level class 4 lasers, and those are not as common. Also big, expensive machines in combination with sort of a regenerative type picture. So not super common, but they are around. There's a few people who use them.
Shockwave therapy can actually cause damage if it's not
It
done
can,
correctly.
yes, yeah. So certainly the focused can, and that's why it's class 3 or 4. So you need to have somebody who knows what they're doing, and we don't do too many to weight-bearing tendons like the patella, the Achilles, because especially if the person is older and they have a lot of degeneration in the tendon, or there's sometimes these have tearing in them, you have to be very careful of doing too much because we worry that it could cause, there's a few little case studies here and there where there's been tearing, and we don't know if it's because the person did too much or the combination, but we're careful of that. Yes.
Is shockwave therapy is it electrical stimulation?
No, it's a sound wave, but it's pushed by the electricity. So it's not like a muscle stim, like you might be thinking about, which is an electricity that contracts your muscle. It's a plugged-in electric unit that focuses a sound wave. So you can't actually see it, but if you put it through a cup of water, you'd see the sound wave going.
Does it generate bone growth? Like, does it help a fracture
Yes,
heal?
so we do use them for higher risk non-union stress fractures, particularly in the dancers, the anterior tibial cortex, and some sesamoids. We use them to help with that. So a little bit like a bone stimulator, which is a pulsed ultrasound machine used for slow to heal stress fractures. We are using shockwave analogous, focused shockwave for those fractures, and we think that it speeds up. There's been some studies to show that it probably speeds up healing, and these are mostly used on the harder to heal, the higher risk stress fractures, not like we put on every stress fracture. Again, they're hard to get, they're expensive, but we do use it for that. Yes.
Does insurance usually, can they pay for Shockwave or no?
Well, no, not specifically. So it would be billed as a doctor's visit or a physical therapy visit, or different systems have. So Kaiser has one in Mission Bay, and they would just bill it. It would be a doctor's visit, but the trainer would put it on, or the physician would oversee it. I'm out of network, so I bill it as a doctor's visit. People pay and they submit it. But if I wrote Shockwave, it wouldn't be reimbursed. And then with work comp, we try to get it for the ballet, but they won't reimburse Shockwave. So it's not a known modality that is covered. So you just say it's a doctor's visit. That's right. Yeah. Yes.
Also, from a physical therapy perspective, and maybe also in the future with PRP, on our end, we have patients who kind of just received it, trying to understand how conservative you want to be in like the more immediate days after, and I feel frequently the instruction just ease into it. And are you really instructing a patient to like really stay away from pain for a period of time and be, like let's do something to keep it really light, or is it kind of, I guess, trying to figure out what the
Right.
best.
Right, great question. So with Shockwave, no real restrictions. Okay, now if they're in a painful phase and we're trying to tone it down, the physician should say like, okay, so pain-free strengthening only, non-weight bearing, shuttle, eccentric, but nothing painful. But there's no true restriction with Shockwave, so it doesn't cause more damage. And there's no risk of doing too much because you have less pain from the Shockwave. It's a good synergistic tool. With PRP, I always give very specific detailed instructions for 12 weeks of what they should and shouldn't do. So if we're needling a tendon, and again, you mix up Shockwave a little bit, but if you're needling a tendon, there are strict guidelines on when to do what. And generally, if we're talking about these chronic tendon problems, you want to be loading in a pain-free range in that rehab process, right? Once you pull them out and try to get it better, and they're not just running through it anymore. So there should be some instructions.
Awesome. Thank you. All right. I forgot to mention, we're in a remodeled space. Everybody do ooh for me. Ooh. We've only been in here a week and we're still working out the kinks, but we're excited to be in here because for the whole summer, 4 or 5 months, we were over in the small little fitness center. And if you are a patient here, thank you for adapting to our change for the summer. And we're excited to be here. Thank you. The next thing, again, PRP. So about 15 years ago, it's been around since about 2000, but 15 years ago, as a patient, or as a physical therapist, a patient came in and I went to Utah and I got these injections in my back and they're called PRP and they went all through my back and I'm better now. And I'm like, okay, but what is that, And so it's always funny to hear these different stories. And so over the years, there's been a little bit more PRP, a little bit more. And then finally, UCSF and Stanford, which tend to be very research oriented and will not do something unless they have research that backs you up. Okay, it's kind of like creatine. They're all saying take creatine now. UCSF and Stanford are now endorsing and using PRP as a treatment. So then we said, right on. Then everybody's jumping on the bandwagon, but what is it and how does it help? And is it something that you guys want to try? So here we go. Here's my little bio. Dr. Sampson is a fellowship-trained sports medicine physician who specializes in non-surgical treatment of musculoskeletal injuries and pain through the body. His goal is to avoid surgery and get patients back to activity as soon as possible. He completed his undergraduate degree in business economics at UC Davis. He then received his MD from Georgetown University. He completed a research in sports medicine at Stanford University. Following, he completed a residency in family medicine in Michigan. Yay, Nikki, Michigan. Prior to his sports medicine fellowship at the University of Utah. You've been a little bit everywhere. Yeah. So he is a Marin County kid. I had the pleasure of meeting his father and watching his father, who is a hip-renowned surgeon in the Bay Area also. And I said, so what's your dad doing? Is he still riding the recumbent bike off of James Street in Mill Valley? He said, no, he's into e-bikes. And now I have to ride with him and keep up with him without the e-bike. So it's good for you. So, welcome.
All right, thank you. I wrote some notes for myself here. So we're going to talk about PRP, or platelet-rich plasma. And so the first thing we want to think about is, a lot of these things are kind of somewhat luxury items. I mean, they definitely can be costly. They're out of pocket. And so it's not always the first line treatment we're going to bring to patients. I mean, the first thing we really want to think about is a good diagnosis. What have they done before coming to us for PRP, for shockwave, for any of these treatments? Because ultimately, if we don't have the right diagnosis, we're treating the wrong thing. It can get very costly very quickly, and it may not have, a good improvement or much effect. So if we're doing it for the right thing, it's a great option for them. Physical therapy is a big part of what I prescribe in my practice. We always want to ask the patient when they first come in and we figure out a diagnosis is, how much can you do right now? If they can do activity, if they can do strengthening, then a lot of times that's the first place that we're going to start anyways. Strengthening tendons, loading tendons, strengthening muscles, finding imbalances. How can we optimize everything first before we get into the fancier stuff? And a lot of times that's where people come in and say, I want the fanciest thing first. And like, what have you tried? If you haven't tried everything else first, it may be worth starting there. In terms of injections, which we're finally getting to now with the PRP, we have cortisone injections, we have hyaluronic acid injections, we have platelet-rich plasma. And so there still is a role for all those different types of injections. Steroid gets a bad rep. There are definitely cases where steroid is a great option for patients, and it's covered by insurance. Hyaluronic acid for the knee, for arthritis, it's covered by insurance. So there's things like that that we should be looking to do first before we kind of move on to things like the PRP. So a lot of times it ends up being kind of the second line option for us, but also how we optimize physical therapy. The other thing that probably all three of us here use is ultrasound in the office. And the idea is we're looking for real-time feedback, not only about when you come into our office, what is going on right now? Can we look at your MRI from 6 months ago, from a year, and we're like, does it really help us? And we want to know, what does it look like today? So if somebody comes in with tendonitis, what does it actually look like today? How does it move? So you have a tool that's great for us to see exactly how things look in present time, which is really helpful. So we're trying to get a good diagnosis, make sure that they've gone through all the right steps first, and then if we get to the point where like, okay, now is this a good option for us to consider? So I asked AI to give me a catchy headline for PRP, and they said, turn your blood into healing power. So that was pretty good. So, the other thing is it can be somewhat unpredictable, and when we think about somebody coming in with late stage arthritis, it's unpredictable. If somebody comes in and they haven't done anything else, it's unpredictable. So we want to do things that are going to be predictable for our patients first. So patient selection, finding people that these are appropriate treatments for, is definitely going to be really important. So for PRP, or platelet-rich plasma, we're thinking about using your blood to basically create a healing effect. So why does that work? When you get a cut on your arm, or if you break your bone, your body heals. So why wouldn't your tendons, your ligaments, or your cartilage heal? It comes down to the fact that certain areas of the body have great blood supply. Your skin is super vascular, so if you get a cut on your skin, it bleeds like crazy, but it stops and then it heals. If you break your bone, it bleeds like crazy and then it heals. So some of these tendon or ligaments areas, they just don't heal very well because they don't have great blood supply. So what we're doing with this is we're taking a sample of your blood, and when we think about blood, there's different components. We'll break it down into 4 basic components. So we have our white blood cells, our red blood cells, our platelets, and our plasma. And we're trying to concentrate down to the platelets and the plasma mainly because that's the part where we have most of the healing effect that it comes from. So the platelets are chock full of growth factors, and so if we can concentrate those down, then we can take advantage of those basically to create a healing response in your body. So it works great when we use it for the right circumstances. So what does it do? It promotes collagen production. It improves blood supply, which we've talked about with some of these other things, reduces chronic inflammation by down-regulating some of the inflammatory pathways, and stimulates healing or cellular repair. So it works really well. So how does it work? You come into our office, we take a sample of your blood, depending on the different system, everybody uses either slightly different systems, anywhere from maybe 10 cc's up to 60 or even 120 cc's of blood. So it sounds like a lot, but when you go to donate blood, they take about 1,000 cc's of blood. So if somebody takes 10 or even up to 60 to 100, it's actually not a ton of blood from your body. So people do fine with that. We spin in our centrifuge. That takes about anywhere from about 5 to maybe 14 minutes. And then we take that concentrated component of your blood, we're usually down to about 3 to 6 cc's of blood, and then we're going to inject that back into an area in your body. So you do it all in the same setting. People say, do you send it to a lab? What are you doing with it? So really the rule is that we have to do everything in the same setting, and we can't manipulate it too much. So we can't expand your cells. We can't do too many fancy stuff where we send it away and bring it back. So the reality is we draw it, we spin it, and then we're going to inject it back into your body in the same setting. So who's it a good option for? So we're looking at things that are going to be a little bit more specific. So peptides are going to work systemically. If you take a peptide, it's going to work on healing for your whole body. If you use shockwave, you can cover a fairly broad area in one setting. For PRP, we're probably going to be down to a much more specific area. So what we're thinking about is people who have chronic tendon issues, potentially having a tendon tear. So if we're thinking about tendinitis over a broad tendon, probably shockwave is going to be a better option because you can cover a much bigger area. We're thinking about tendinitis if it's more focal, that might be a better option for patients with PRP. Partial tears, that's a great option for PRP because we can actually target specifically down to where the tear is. Shockwave could be helpful for that, but this is going to be a little bit more targeted with where we're putting it. And then arthritis is a big one as well. So if somebody's end-stage bone-on-bone arthritis, it's probably just not a great option for them. Mild to moderate arthritis is probably going to be where it's going to be a much better option. Ligament tears, muscle tears, you can start to kind of use it wherever you want. The question is, specifically where on the body, it kind of depends. Sometimes it works well, sometimes it doesn't. And so the issue is sometimes it is a little bit unpredictable for us to tell how well it's going to work. The question I usually ask people is, have you done it before or somewhere else in your body? Somebody's done PRP for their shoulder and they're coming in for their knee. We usually predict there'd be a higher level of success if they've already done it before in their body and it's worked well somewhere else. Because it's from your body. So we don't know how well it's going to work. It's not a standardized medicine. It's not a standardized pulse of energy. It's specifically from your body going back into your own body. Typically, we have you not take anti-inflammatories for about a week leading up to it. So we're using your platelets to help with the healing. So we don't want anything that's going to inhibit platelet activation. So the most standard thing is NSAID or ibuprofen, Aleve, that kind of medicine. And then also we want to have you hold it for a week or a couple weeks afterward. Same thing. We're trying to keep the platelets activated. We're trying to not inhibit what we're going to do. That being said, we see college athletes, we tell them to do a bunch of stuff, they ignore every single thing we tell them to do, and it still seems to work quite well. So it's probably a little bit precautionary that we're telling them to do that, but we stick to it for now. Also in terms of rest, so kind of depends on where you're focusing. If you're doing it into a joint, we're not creating as much of an injury for a joint. We're basically just entering the joint space. It's going to spread. So we want to give them time. So usually have you take it easy for about a week. We give more specific protocols versus a tendon. Like Chris was saying, if you are injecting your tendon, we're actually straining your tendon on purpose. So what does that mean? We're poking into the tendon and we're creating an injury on purpose, partly because your body's been stuck in this kind of like chronic non-healing loop, and so we want your body to recognize there's a new injury along with having all the healing stuff ready to go right in that space. If you look at people who even just have tenotomy where you just poke into a tendon a couple times, that can create a healing response even without the plasma component to it, because we're stimulating the natural healing response of the body. So we're trying to figure out, depending on where we are in the body, we should probably tailor what the aftercare is going to be like. Also, if somebody's had PRP done before, some people have done it all the time, they know exactly what to expect. We don't have to limit them as much if they kind of know how to tailor it to their body, or they know how to kind of regulate what they're going to do afterwards. No matter what we do, whether it's shockwave, whether it's PRP, whether it's cortisone, really a big part of what we need to do is we need to get somebody to go out and load the tissue afterward as well. And so part of healing is you got to load the tissue. So if you go into a tendon tear and you stimulate healing and then they don't use it, it's not going to help as much as if they do it and then get the healing response and then get the person to go out and actually load up the tendon. but you want them to start to use the area, because part of it is we're doing this to get to the next step, which is you can load the tissue, you can go back to doing activity, and you go back to sport. So a big part of everything that we're doing is if somebody feels great sitting on the couch, but they don't feel good going for a walk, they don't feel good playing pickleball, playing tennis, that we still really haven't done our job well. Typically, patients who have complete tendon tears, unless a surgeon tells them we're not going to do surgery for it, that's not a great option. People with end-stage arthritis, it's also not a good option. Or people who have done it before and it just did absolutely nothing for the same area, and they like to say, hey, we'll just do it again, we're going to do it better than the last person. It's also, there is a skill component to this. So I think all three of us do quite a few injections, and so there could be a provider to provider difference for things like PRP. If somebody comes in and said, I did it and it didn't work, the first question we're probably asked is, well, how did they do the injection? You know, somebody did not use an ultrasound machine or did not use guidance, and we always question, were they in the right spot? You know, could they have potentially been in the tendon, but they are really just going by feel, and so is there a chance that they just didn't get it kind of correctly, or the technique wasn't something that we thought would work well? So there's definitely kind of a skill base to this, so somebody who does it all the time is going to be better than somebody who just kind of does it occasionally. And then it takes weeks to months to see an improvement. So for healing, when we think about steroid, a few days in, boom, it works, you feel good, everybody's happy, but the problem is it doesn't actually heal anything, we're reducing symptoms. And for a lot of people, that's fine for what we're trying to accomplish, but for healing, it's going to take time. And so, you have to prepare people. This may take weeks and even sometimes months to get the full benefits of it. So we just have to kind of understand, who are the right patients, what are the right settings, and for everybody it's different. Where you might have the right patient, you feel like it was the right indication, and it still doesn't always work. And part of it is each person's body is so different, so that we can't standardize what we're doing with this. We standardize the technique, but for each person it might be a little bit different experience, just because it's coming from their own body, going back into their own body. So it's a great option for folks, but probably something that we have to make sure we're using in the right setting, and also it can be used in conjunction with other things too. So we're talking about this before, like Shockwave plus PRP. If somebody has the ability to afford doing both of them, we're happy. We're like, hey, go do Shockwave first, break up adhesion, scar tissue, promote healing, come back in and we'll focus on the tear or the parts that maybe didn't heal. And you could definitely combine it with peptides in the right setting as well, because we're trying to promote healing. So, any of these can kind of be used in conjunction with each other, to promote healing. A lot of what we do is, symptom reduction plus activity, and for a lot of people, that's totally fine. But for things that we could heal, we're trying to get into that realm of, all right, we have these options now to promote healing, and unfortunately, insurance doesn't cover anything that, if you say the word healing, it's not covered. But that's the goal. Eventually, we want to start with the healing options first, because the goal is to get rid of it, these issues, and to actually promote healing, and ultimately, I think that's where we need to go in medicine. We're not quite there yet. Sorry, questions?
So, like hyaluronic acid over time, it sort of wears off,
Yeah.
So PRP, do you feel like it doesn't wear away after time, or is it?
Great question. So if you're using it for arthritis, then it's gonna wear off over time. So for the tendon issues, we're hoping to promote healing. So we want to get it to actually go away and heal. If it's an arthritic joint, we're probably going to be somewhat comparable to hyaluronic acid, where eventually it's going to wear off. So there's going to be a level of maintenance that you're probably going to need in terms of injections.
I've heard it used for spinal issues, for disc regeneration perhaps, or maybe just general arthritis in the spine. I've heard some doctors propose it, and I've heard some doctors say it's snake oil. So I don't know, whether that's an appropriate place where it could be used, or whether it's effective there.
Great question. So definitely gets used intradiscal. It shouldn't be the first line though. I think it's for somebody who's probably tried alternative options first. The idea with the disc, once you've lost it, it extrudes, can we get it to kind of plump back up? And the question is, does it work or not? I think it's probably very dependent on person to person. I wouldn't put that as the first line option for degenerative disc disease to inject into the disc. But I think if somebody is doing well, or they're looking for something to augment what they're already doing, as long as we don't cause harm, it's okay. If you can financially afford it, if you're looking for something that potentially comes with benefit, it's reasonable. But it's definitely not a first line option. For facet joints when they're arthritic, same thing. When ablation is so kind of well studied and understood of how well it works, that are we going to regenerate cartilage? Probably not from platelet-rich plasma. Can it provide benefit in terms of joint arthritis-based pain? It potentially could, but I probably wouldn't recommend it as a starting point for most folks. Other questions?
How about meniscus tears?
Yeah, so meniscus tears seem to be less. We operate on them less now than we used to.
Right.
I kind of look at it if there's a mechanical aspect of a meniscus tear. So if you're locking and catching, if you're unstable, if probably have pain that's just pretty severe, or just get these recurrent effusions, then we may not be able to heal those. People who are doing well and are trying to kind of improve the benefits of recovery, I think it's a great option. It's good for mild to moderate arthritis. It can promote some level of healing. Is it going to truly heal the tear? Probably not, but can it add some level of healing to it? It probably can. So it's a great option for the non-mechanical based meniscus tears, at least from what I've seen.
Would this have any good benefit for someone with an atrophied psoas muscle?
Great question. So strengthening is definitely going to be the top choice, for atrophy more than anything else. I can't say that it's going to promote hypertrophy alone just by injecting it. I think it'd be one of these things that if you're doing well with strengthening, or if you can't strengthen because of pain, if your tendon, your iliopsoas tendon is causing pain, it's probably going to be more to treat the tendinitis than probably the atrophy itself. I still think you're probably number 1, 2, and 3 are going to be strengthening, but definitely be the top.
Thank you.
Thank you.
Are there any questions for any of the group here? Does anybody have any questions? Okay.
For erosive gastritis of the stomach caused by taking too much Advil over many years, would any of these therapies be beneficial?
BPC, because it is made by your stomach, actually, in an oral form, a pill form or a liquid or an oral form, I think it could be. Yeah. Then they'll say that online. I've read that, and I've read about studies where they've tested it for treatment of gastritis and other inflammatory issues.
Have you tried that with any of your patients? Has that come up in your practice?
I haven't tried the oral form for any of my patients, but I have had patients who have used an injectable form and said that it helped some of their gastric issues. So even though they injected it, it got to their stomach as well.
Jess?
I just have a question as a provider, us who aren't necessarily recommending or administering these because we don't have access to them, but I do have patients that are taking peptides and things. When you talk about the people who are dipping their toes in the water, do you give them timeline recommendations? Should we say hey, try this for 2 months and then get some lab work done to see, or what's your baseline of hey, if you're trying this, here's the criteria, but also get this right after. Do you have a kind of frame for us?
I have a framework for it. They're different with every peptide, and it's different with every person and the concerns they might have, but we keep talking about BPC, we can talk about that as an example. With BPC, I want to see, did their growth hormone go up? Because it does increase that, so did their IGF-1 go up? Did that cause any changes in their metabolism? Did that cause any changes in their weight? Did that cause any changes in muscle mass? And then also I like to check, did it change, always check kidney function, always check CK level, always check TSH, did it have any impact there? So just a standard panel that I've developed. And there are a few great books that are written by MDs about it, taking all of the research, coming up with protocols. And while that's, it's still with the data we've got, at least that's another source of data. Is this? Here's a protocol for how to do it, how often to take it. So that's usually what the framework that I use.
Molly.
Well, I texted you that thing and I don't have my phone, but I know someone who, her husband, they went to Toronto to get an injection of a gel-like substance that starts with an A, like Rismethat or something like that. I don't know. But I didn't know if you guys had heard of that or is that coming here at some point?
It's definitely not approved in the United States right now. And there's non-absorbable hydrogels that they're starting to inject. And so it's kind of like a hyaluronic acid, but it doesn't get absorbed. So the idea is that it needs to make like an actual cushion in the joint. So we didn't see any studies in the U.S. Somebody came up with it and we looked it up. There's no studies in the U.S. right now where they're like actively taking participants, but I imagine it's probably going to eventually.
But I would imagine Canada and Europe have studies, right?
Yeah, somebody's flown to Canada to do the actual. And we have Canadians here actually.
And it's like, I think Sterling or one of them was in Canada. I had patients bringing them in before they came to the US. So we're a few years behind with FDA approval for some of those things. They show up there first, Europe, Canada.
Some of my young therapists back there in 10 or 15 years, you're going to be up here doing this talk and you'll say, oh, 10 to 15 years ago.
Right.
I tag you guys are it. One last question. Who's got the one to close down the show? Yes.
I'm still a little confused about how one would get peptides. Let's say you want.
The dark
Can you
web.
walk into a Walgreens, go to natural medicine and pick it off the shelf, or because you mentioned you can't prescribe it. So how does one get it?
You go online and you say, I want to buy peptides into your AI, and it says, here's the top site, and you say, oh look, there's that BPC he was talking about. I could literally create an account right now and it'll be here by Monday.
Yeah, but there's a lot of those sites.
Yes, there are. Yeah, there really are.
And they look good, but they're somewhere off in Russia, and you don't know what you're gonna get.
China.
Yep, my dad was, I'll just out my dad, he was saying, I'm using semaglutide. I'm like, where'd you get it from? And he told me the compounding pharmacy who got it from. So I called them, I said, where are you getting all your stuff from? And they said, well, this and this, and where are you getting that one from? Well, that we get from China. So there are cheaper ingredients in some countries, and some of these labs will use the cheaper ingredients because this is a business decision.
And there's a tariff.
Yeah, right, yeah, might go up. So, yeah, that's how you would get it. But if you saw me, I would give you some other ideas about how you would get it. But basically, it's the Wild West.
And so maybe UCSF and Stanford in 10 years will be doing peptides.
Yeah, I think in 15 years, these will be all over the place in a much more regimented and regulated way.
Well, I might be super old. I want to know.
You'll look great because you'll be using BPC.
There you go. My growth hormone. So.
Dr. Masker?
Yeah.
Well, I'm gonna allow you to come up and ask individual questions because some of the staff here need to work tomorrow at 7 a.m. And please help yourself to food and wine. And those of you that have personal questions, come on up. So thank you all for coming.